Welcome, everybody. My name is Kelly Piper, and I'm at the California Healthcare Foundation, and we're really excited about doing a webinar today to share county snapshots that we commissioned from the Urban Institute. These snapshots came out of a question that we have seen repeatedly across California. How do you know if you're building up enough addiction treatment? Where can we find out how many people with opioid addiction we have within our county borders? How do we know what resources we currently have in place and what's the treatment gap? And that's what we asked Urban Institute to solve for us. So I'll be going through a brief overview of what California Healthcare Foundation is doing around the opioid epidemic, and then turning it over to Lisa Clemans-Cope from the Urban Institute to walk you through the snapshot. This is the second webinar we've done because after the first webinar, we got some very helpful feedback about the snapshots and some of the data assumptions. So Lisa and her team at Urban Institute revised the snapshots, so we're showing you the latest version with the latest assumptions. Because we've got a lot of people on the line, we've muted all of the lines. We are recording the session, and the recording and the slides will be available to everyone at no later than a week from today. If you have a question, type in your question in the Q&A box. You can also raise your hand at the end, and we will open up the line for you if it's easier for you to ask the question verbally. And if you have a logistical question, please ask the host. So again, I'm Kelly Piper, and I'll be kicking us off and then handing it off to Dr. Clemans-Cope. So just to start off, for those of you who haven't met me or heard me speak before, I usually like to start off with the acknowledgement that I'm a family doctor, and I was part of the problem. I was one of those doctors who was trained to give opioids liberally, that we thought we were helping people. This was reinforced by all of our medical education and the Medical Board of California and regulations that were measuring quality. And of course, we learned to our horror that we were harming the very people that we thought we were helping. And one of the most painful things about the opioid epidemic is that even though alcohol and tobacco kill far more people than opioids, neither smoking or drinking is likely to kill you in your sleep tonight. And it's the suddenness and rapidity of death due to opioid overdose that is what's really created this national tragedy and lost so many decades from young lives. Next slide. So we've looked at this extensively with our partners across the state, and there's many, many activities happening to try and stop the opioid epidemic. So we at the California Healthcare Foundation really focused on the healthcare delivery system, have focused in 4 areas where the best evidence shows that we can stop deaths, because that's our primary focus, is how do we lower the overall opioid death rate in California. And that's first preventing new starts, because you don't die of an overdose if you never get started on the path of opioid dependence or addiction. It's safer management of chronic pain, so specifically looking at those people on high doses or those using opioids and benzodiazepines or sedatives together, because those are the folks at highest risk of death. It's treating addiction effectively with medications, because for opioid addiction, treatment without medication almost always fails. And finally, we have to stop the deaths. Until we have enough treatment, until treatment is easier to get than street drugs, we need to make sure to keep people alive, and that's through making Narcan widely available, through needle exchanges, even supervised injection sites. So just a quick look at our data of how we're doing, and then I'm going to pass it on to Lisa to talk about the snapshots. All of the data that we have is available on the opioid dashboard that's put out by the California Department of Public Health. If you haven't gone on this dashboard, I highly recommend it. You can click on your county and see a snapshot of the county report that's pre-packaged and ready to use, or you can explore on the website and look at overdoses, prescribing, Suboxone prescribing by race, ethnicity, age, zip code. It's really powerful. And so to quickly look at how we're doing across California in our 4 main areas, looking at prevention, I'm really proud to show that from the peak in 2010 in California, we have dropped the total number of opioids prescribed by almost 40%, which is doing well, given that we're prescribing double or triple the rates we did 15 years prior. And the reason this is so critical is it's now quite clear that the more opioids you expose the population to, the higher risk of long-term use. And there's a great study that showed for every single day you take opioids more than 3 days, you increase your risk of long-term use by 1%. So it really means almost 1 in 4 people using opioids long-term if they take them for a full 30 days. And that has a lot of policy implications about how many opioids we should be giving after minor surgeries or after injuries. Next slide. In the area of management, we also in California have done well. We've dropped 50% from our peak in terms of the number of California residents who are using high-dose opioids. And the reason this is so critical is that we've got good data to show that on high-dose opioids, which in this case is defined as more than 120 milligrams of morphine equivalents, which is essentially the equivalent of 24 Norco in one tiny pill or a couple pills. Your death rate goes up 9 times if you're taking that level of opioids compared to low-dose opioid use. And even more strikingly, if you add benzodiazepines, Valium or Ativan, your death rate is 10 times as high compared to people who take opioids alone. So we know that this is a population that we really want to focus on, not removing opioids from everybody, not taking it away from people using low doses who are stable, but really focusing on those high doses and those combinations. In terms of treatment, we also know that access to treatment drops overdose death rates, and we're up 50% since 2010. So this is the area we realize we still have a long way to go. We have not met the demand, but we're moving in the right direction. And for those of you who have not yet been sold on MAT, this is one of hundreds of studies showing the close association between maintenance on medications and death. So in this case, if you are on methadone maintenance, your death rate is 1/3 compared to those who are given methadone briefly to get off opioids and then detox. If you're on buprenorphine maintenance, your death rate is half that of if you were put on buprenorphine briefly to detox. It's just crystal clear that the maintenance is standard of care, and detox dramatically increases death rates. Next slide. So in terms of stopping deaths, our 4th category, there's good news in California, which is we've stabilized the death rate. So while the rest of the country has been increasing, for example, parts of California were as high as Ohio in terms of the death rates in 2014. Ohio's increased 70%, and we have stabilized. Our overall death rates flattened. But the orange line, which is fentanyl, is really our wake-up call, because fentanyl overdoses are steadily increasing in our state, and that's, again, why we in California are focused so intensively on getting treatment available, because that's the only thing that's going to stop that fentanyl rise. Next slide. 21% in the last year. So we have a long way to go. Next slide. The last thing I'll say is there's a work across California to essentially get to the place where anywhere you go for treatment, that's going to be the right door, that we're a no wrong door state, that if you as someone with addiction show up in primary care, if you call your health plan, if you go to an emergency department, if you go to a hospital, if you're incarcerated, if you go to a mental health clinic, we want to make sure that no matter where you go, you have access to evidence-based treatment. And these links in these slides will take you to active projects in each of these areas where we've been working to try and increase addiction treatment across the state. Next slide. So now I'm going to hand it over to Dr. Lisa Clemans-Cope to talk about the question we asked her. How do we know county by county if we have enough treatment, and where are the gaps?
Hi, thanks, Kelly. I'm Lisa Clemans-Cope, a PhD health economist at the Urban Institute, and this research was completed in collaboration with my colleagues Marnie Epstein and Doug Wissaker. Urban is a nonprofit, nonpartisan policy think tank, and we're in DC, and we're grateful to the California Healthcare Foundation for funding this work, and also for the collaboration with Kelly Pfeiffer and James Gasper, as well as a lot of reviewers of the analysis. We received a lot of feedback on the report when we first released it a few months ago. And since then, we've made some updates on key parameters, which I'll talk about a little bit later. And we also made a small update to the LA Service Planning Area fact sheets to reflect some revised measures that were put from the California Opioid Overdose Surveillance Dashboard. Next slide. So to respond to the public health crisis in California related to opioid use disorder, county level estimates are really critical for informing the decisions about where to invest in additional treatment capacity and where it's most needed. So we did this study because it wasn't known which counties had high treatment rates compared to their treatment capacity, let alone how many providers were needed in a particular county. So as you all know, we produced fact sheets of county level estimates that drew from existing sources of data and from computations of new key county level indicators, including the prevalence of opioid misuse and opioid use disorder, opioid agonist medication assisted therapy, treatment capacity, including buprenorphine and methadone treatment, the treatment gap by county, otherwise defined as the number of people with opioid use disorder who cannot get treatment in their county, and the approximate number of new buprenorphine prescribers needed to meet the treatment gap. So just to overview the findings, we found that in almost all counties, there were substantial gaps between the treatment need and capacity. So for example, defining opioid use disorder as past year abuse or dependence, we found that adding 3,525 new prescribers across California would fill only about a third of the treatment gap if all prescribers treated half of the number of patients they were allowed by their waiver limit. Next slide. Yeah, that's it. There are a couple of published papers examining the supply of certain providers, such as buprenorphine waivered prescribers, and these studies, but these studies don't provide county estimates, and just a handful of the studies have examined supply relative to demand. The paper that we drew on most in terms of the methodological approach for this research was the Jones paper from 2015. And in that paper, Chris Jones and his colleagues estimated national and state trends in opioid agonist medication-assisted treatment need and capacity to identify gaps and inform policy decisions. And they defined opioid use disorder as past year opioid use or dependence, consistent with a definition developed for the DSM-4. And we used the same definition for the main measure in this version of the fact sheets. Jones's results showed significant gaps between treatment need and treatment capacity, and he showed California's treatment gap was approximately equal to the US average treatment gap. With respect to potential buprenorphine treatment capacity, California was estimated to have a gap of at least 4 patients per 1,000 people, similar to the gap nationally. Moreover, the majority of opioid treatment programs, those are methadone clinics in California, were reported to be operating at about 80% capacity or higher, implying that a substantial increase in patient load would be difficult for them. Okay, and now key data. We compiled our data from a number of different data sources. First, we analyzed county measures from the California dashboard that Kelly was talking about. To compute treatment capacity, we used data from the California Cures database, as well as DEA Active Controlled Substances Act Registrants database, which is data, which contains data on all prescribers registered in California, including the waiver limit for data waivered providers. Prescribers are listed by zip code, and we geocoded them to counties using the Google geocoding API in R. The treatment capacity also used data from California's opioid treatment programs and from the SAMHSA OTP directory. We used SAMHSA's past year estimates of non-medical use of prescription pain relievers, also called opioid misuse, for 26 sub-state regions in California, and we computed the opioid use disorder rates for by using additional data from the National Survey of Drug and Alcohol. I'll discuss these 2 measures more in more detail in the next slide. Next slide. Let's see. Okay, so can I go to the previous slide? Sorry. Yeah, that, okay. So we obtained past use, misuse of prescription opioids or heroin by sub-state region of the NSDA, which is the national survey data set. Misuse of prescription pain relievers is defined as use in any way not directed by a doctor. And we used OLS regression models to predict county level misuse, and then to estimate the county opioid use disorder rates from these other related rates, we applied a rate, a national rate of the opioid use disorder among those who misuse opioids, which is about 18% of those who misuse opioids, to compute the county opioid misuse, rates. We calculated the MAT treatment capacity by county by compiling the data waiver prescribers by waiver limit and the total OTP slots by county. We then looked at the treatment gap, assuming all individuals with opioid use disorder seek treatment. And lastly, we calculated the number of new buprenorphine waivered prescribers that would be needed to fill the treatment gap, assuming all individuals with opioid use disorder seek treatment. Next slide. So I wanted to talk about the two changes that we made from the previous version. So the first is that we use a narrower definition of opioid use disorder. In the previous version, we used opioid misuse as a proxy for opioid use disorder. And in this revision, we've used a narrower definition defined as opioid abuse or dependence, which is more consistent with the DSM-4 criteria. We're able to separate out opioid use disorder from opioid misuse by digging into new research for an estimate of the share of people who misuse opioids who have an opioid use disorder. Secondly, we received feedback that the previous definition of the treatment gap as 20% of those in need was arbitrary and difficult to understand. So to address that, we redefine the treatment gap as being all people who have opioid use disorder and don't have access to treatment, methadone or buprenorphine treatment in their county. So it's a much more straightforward count of the gap. Next slide. So this is a fact sheet example. I'll first give an overview of the fact sheets. As we mentioned, we published the fact sheets for each California county and the LA service planning areas. This example's fact sheet is for California totals. The top section of the fact sheet contains key measures like the percent and count of people in the county who with opioid misuse and opioid use disorder. And the box plot shows the spread of the opioid use disorder rates across the counties, with the particular county highlighted in blue. We're going to talk more about the box plot in the next slide. And the first two rows of the table show two measures from the dashboard, opioid overdose deaths and buprenorphine prescriptions. The next two rows show the two measures of treatment capacity, the number of methadone patients at OTPs and the number of buprenorphine waiver prescribers. And the next few rows in the table show the opioid use disorder rates, the treatment capacity, the gap in the county, and the number of people with opioid use disorder who don't have access to treatment in the county. And the bottom part of the table contains the recommendations about strategies to meet the treatment gap. Next slide. So to go a little bit more in depth to explain the box plots, each dot in the chart shows the estimated rate of opioid use disorder among those 12 and older in the county, and the featured county's rate is shown as a blue dot, while the other counties are shown as gray. The box plot in this chart shows the spread and the average of the rates in all the counties, and the box in the box plot has a middle line that shows the median range, the median rate across counties. And the ends of the box show the rate at the lowest quarter of the counties and the highest quarter of the counties. Next slide. This slide and the next two show overview maps of California county death rates and then the current treatment capacity. So here, looking at the death rate due to opioid overdose in 2015, the California overall crude death rate was 5.8 deaths per 100,000 people 12 and over. And the median death rate for the counties were 4.5. 5 counties did not have, had no deaths due to opioid overdoses, and the maximum crude death rate was 19, and that was Humboldt. Next slide. So we wanted to also emphasize that in California, only 2.4% of all prescribers have a buprenorphine waiver. This ranges from a minimum of no buprenorphine waivered prescribers in Alpine and Sierra counties to a maximum of 10% of prescribers with a buprenorphine waiver in Modoc. Next slide. We used patient count data from the SAMHSA's OTP directory to estimate methadone treatment capacity in California. At the time we pulled the data, there were 152 registered OTPs in California, located in 135 unique locations. This was in 2016. And there are an estimated 46,430 methadone slots, assuming the current OTPs are operating at about 80% capacity. So 35 areas, that includes counties and LA spas, have an OTP, and 29 counties do not have an OTP. Next slide. We're now going to talk through the process that we use to calculate the treatment gap and the number of new prescribers needed. So we used 2 estimates of the number of patients that each waivered buprenorphine prescriber would treat. Our lower bound was that all prescribers treat only 9 patients, regardless of the waiver limit. This is based on California-specific estimates in a paper by Thomas from 2017. In the upper section of the flowchart, marked by gray arrows, shows the estimates under this lower bound. The upper bound treatment estimate was that each prescriber would treat half of their maximum waiver capacity, shown by the black arrows in the flowchart. This produced a low and a high estimate of treatment capacity. And we subtracted the lower and upper bound estimates of treatment capacity from the number of patients with opioid use disorder in order to compute the treatment gap, or the number of individuals with opioid use disorder who don't have access to MAT in their county. Following the 2 assumptions of how many patients each provider would treat, this produced 2 estimates of the treatment gap. Which you see. Last, we computed the estimated number of additional 30 waivered buprenorphine prescribers needed per county to achieve the capacity to fill the estimated treatment gap, using both assumptions of how many patients each prescriber treats. We call this the estimate of new prescribers needed, the uncapped estimate, and we'll explain that in more detail later. You can refer to a methodological appendix on our website that describes all of this in more detail. Next slide. I want to walk you through the process that we use using actual data from Butte County. These numbers are reflected in the Butte fact sheet on our website. In Butte County, the DEA data indicates that there are 35 buprenorphine waivered prescribers, 25 have a 30 patient waiver limit, 6 have a 100 limit, and 4 have a 275 waiver limit. There are also up to 64 providers from out of county who prescribe to patients in the county. And there are 474 methadone patients at OTPs in the county. So taking into account all of these numbers, we estimated that between about 1,000 and 2,000 people could be treated given the current capacity, with the lower estimate being related to the lower estimate of the patients per prescriber, which is that all prescribers treat 9 patients, and the higher estimate being related to the higher estimate of patients per prescribers, which is that all prescribers treat half of their waiver limit. Since there are about 2,500 people with opioid use disorder in Butte County, this results in a treatment gap of between about 200 and 1,300 people with opioid use disorder who don't have access to MAT in their county. So if all prescribers treated an average of 9 patients each, adding 150 prescribers with a 30 patient waiver limit would fill the treatment gap. If all current providers treated half of their waiver limit, the new prescribers with the 30 patient limit treated 15 patients each. 14 new 30 waivered prescribers would be needed to fill the treatment gap. Next slide. So the issue is that Butte only has 35 prescribers currently. So adding 150 new prescribers with a 30 waiver limit was deemed to be infeasible. This was when we discussed it with Kelly and James. It just seemed like it was not an attainable goal. So during the analysis period, we set some different limits, and in the final product, we limited the number of new prescribers presented in the fact sheets to this capped estimate, so that at a maximum, we are suggesting that the county double the current number of prescribers. We call this number the capped number of new prescribers. So to reiterate, the capped number of new prescribers is either equal to the uncapped number of new prescribers, if that number would not more than double the county's current prescribers, or we present the number of new prescribers that would be needed to double the current prescribers. These two options for each of the low and high estimates can be seen in the middle column of this chart. So in cases where we present the number of prescribers that would be needed to double the county's current prescribers, we also present what percent of the treatment gap those new prescribers would fill. And we hope this strategy presents a more feasible plan for counties to consider. Next slide. I just want to throw an example in Butte. So if all prescribers treat 9 patients, then the county would need 150 new prescribers. Since the county only has 35 prescribers, adding 150 prescribers would much more than double the current number of prescribers. So for this estimate, we report that the county would need to add 35 prescribers, which would double their current number of prescribers, and that these new prescribers would fill 23% of the treatment gap, assuming all prescribers treat 9 patients each. However, for the other estimate, if all prescribers treated half of their maximum allowable waiver limit, the county would need to add 14 new prescribers to fill the treatment gap. Since this would not more than double the current number of prescribers, we report that Butte would need 14 new prescribers to fill 100% of the treatment gap. I hope that it gives you a good feeling for what the capped and uncapped estimates are. So next slide, please. So just to reiterate, in the cases where the number of new prescribers needed to fill the treatment gap would more than double the current buprenorphine prescribers, we provided an alternative, more feasible strategy of doubling the number of buprenorphine waiver prescribers in the county. There are actually only 4 counties where neither estimate is capped: Alpine, Modoc, San Francisco, and Yuba. And there are 16 counties where only the all prescribers treat 9 patients estimate is capped. And there are 44 counties in which both estimates are capped. Next slide. This map shows the percent of the treatment gap that would be filled by the capped number of new prescribers if each prescriber treats 9 patients. Across the entire state, the treatment gap would be filled by 15% if all prescribers treated 9 patients. And there are only 4 counties where this estimate of the new prescribers is uncapped, and the treatment gap would be filled 100%. Those counties show up as the 4 black counties on the map. San Francisco is very small and hard to see. The minimum percent of the treatment gap that would be filled by the uncapped number of prescribers if all prescribers treated 9 patients is 2.2 in Kings County. Next slide. This is the last map I'm going to show. It shows the percent of the treatment gap that would be filled by the capped number of new prescribers if each prescriber treats half of their waiver limit. Across the whole state, the treatment gap would be filled by about 32%. There are 20 counties in which the estimate of new prescribers is uncapped, and the treatment gap would be filled by 100% to 100%. The minimum percent of the treatment gap that would be filled by the capped number of prescribers if all prescribers treated half of their waiver limit is 4.5 in Kings County. Next slide. I want to run through the overall state estimates, and this slide shows results. The results show that across the state, there are an estimated 3,500 people in California who reported past year opioid use disorder. There were almost 5,000 prescribers with a buprenorphine waiver across the state, which comes out to an average of only about 2.4% across all California prescribers. 81% of those with a waiver had a waiver for a 30 patient limit, 19% had a 100 patient limit, and 4% had a 275 patient limit. We estimate that about 104,000 to 191,000 people could be treated given current capacity, with the lower estimate being related to the lower estimate of 9 patients per prescriber, and the higher estimate being half of their maximum patient limit. The estimated statewide treatment gap for people with opioid use disorder who don't have access to treatment is between 166,000 and 245,000. Rolling up the uncapped estimates of new prescribers needed to fill the treatment gap in the state, that is the estimate of how many prescribers are needed to treat everyone with opioid use disorder. We estimate that the state would need at least 11,000 new prescribers if all prescribers treated half of their waiver limit, or about 28,000 new prescribers if all prescribers just treated 9 patients. If we cap the recommendations or limit the recommendations so that no county more than doubles their current number of waiver prescribers, we estimate that adding about 3,500 prescribers would fill about 32% of the treatment gap if all prescribers treated half their waiver limit, and adding about 4,200 new prescribers would fill about 15% of the treatment gap if all prescribers treated 9 patients. That is, so adding either number of new prescribers would cover less than 1/3 of the people with opioid use disorder in California. Next slide. We have a limitation slide here. This study has several limitations, and I'll just mention one that has the one big one. The one that has the most impact on the estimates is that that we use the estimate that all people with opioid use disorder are likely to be seeking treatment. And this might be high. Currently, about 20% of people who need treatment are seeking treatment. The estimates are sensitive to how many people are seeking treatment. Next slide. Lastly, we just want to note that the clinical impact of increasing the number of buprenorphine waiver prescribers has not been documented to a great extent in the literature yet, but the buprenorphine MAT treatment has been shown to be highly effective in a vast of research literature. And we note that many individuals with opioid use disorder need access to more intensive treatment than outpatient MAT treatment. They may need residential and inpatient services, and many individuals need treatment for substance use disorders that co-occur with opioid use disorder and also with comorbid mental health conditions. Next slide. So to wrap up what this study found, the findings demonstrate that opioid agonist treatment capacity in California counties shows a significant gap between treatment need and treatment capacity. And the gap is particularly sharp in some of the counties with the greatest treatment needs. So both short and long-term strategies are going to be needed to address the gaps between need and capacity. We also want to thank everybody who has given feedback. We are so grateful for people who have studied the results so carefully, and we want to welcome more comments either now or just feel free to email us later. A lot of people will just email us, and that has been really strengthened the research, and we really appreciate that. So thank you. I'd like to turn it back to Kelly. Oh, sorry. That was actually my last slide. Or is this?
Well, we're now open for, hi, this is Kelly Piper. Thank you, Lisa, so much. Really appreciate the presentation, and there's so much information and so much detail that I imagine it may take some time to digest and look over the snapshots. And we hope that this information is helpful to local leaders as they try and tackle the problem of the epidemic in their own community. I just pulled up on the, for this slide the recommendations that we put in about the variety of strategies that are available for local communities. It's while the epidemic is severe in many parts of our state, there's also been a very robust response. And so there's lots of options, not that these are easy to implement, but we're working all of these levers at once to hopefully get to a place 5 years from now where no one has to travel to get the care they need when they need it. So please raise your hand if you have a question that you want to speak verbally, or use the Q&A section if you have a question that you'd like to tee up. And Shalyn, I can't see the hand raising part, so just let me know if someone is going to be speaking. All right, we'll keep the line open for a couple more minutes if anyone has any questions. In the meantime, I'll just tell a quick story to close our webinar. Many of you who are New York Times readers may have seen the piece on Humboldt County that came out on Tuesday. Really a bleak piece talking about the devastating impact of IV drug use and the opioid epidemic in Humboldt County. And what we're going to be publishing later today, a blog response from local leaders in Humboldt County, because one of the things the New York Times piece left out was the incredible, robust efforts in Humboldt County in the primary care system, which is their open door health center system, in local hospitals, both in the emergency department and in the inpatient setting, and their efforts to become part of the hub and spoke model, which allows hubs, which are traditionally known as methadone clinics, to expand their services to all MAT options and to work collaboratively with the community to help manage patients who are too complex for primary care treatment with Suboxone or naltrexone and need methadone administration. So keep your eyes open for that piece. We're really happy to be able to tell the story of Humboldt County, small but mighty, really working hard to make sure that people can live in a county and not die from the ravages of this epidemic. Humboldt County, as I mentioned before, had death rates as bad as Ohio 2 years ago, and while Ohio's increased by 70%, Humboldt County's been able to hold their death rate flat, even with fentanyl in the community. So it's a huge accomplishment. More to be done for sure. Until those death rates drop, we won't be satisfied, but it was very exciting. I don't see any questions. Shalyn, do we have anyone raising their hand?
No, I don't see any questions.
Okay, well then we'll close our webinar, but you do have our contact information. Please reach out to us if we can provide any more information. Thank you, Lisa, for a great webinar.
Thanks.
Have a good afternoon.